coming tonight to our final event as part of our short course series on marginalised groups. Over the past 6 weeks, we've spoken about various marginalised groups in society, from the homeless to prison populations, to those with disabilities, as well as those from the LGBT community. And tonight, we're concluding our short course focusing on migrants and refugees. We're really proud to be collaborating with STAR here this evening. STAR are Students for Action Refugees based at King's. They're a national network of university groups collectively working to raise awareness of refugee issues and promote the integration of refugee and asylum seekers into UK society. They run multiple volunteering programs and fundraising campaigns that work towards that goal. And it gives me immense pleasure this evening to welcome to you our speaker, Claire Zhang, who is the National Migrant Health Lead and Inclusion Health Officer at Public Health England. She also works on migration research at UCL as a clinical research associate. And prior to public health and academia, Claire worked in healthcare improvement and as a speech and language therapist in the UK and Australia. Claire was also a part of Students for Global Health as a student. So it's really great to have her back here this evening delivering the talk. So without further ado, over to you, Claire.
Thank you, Haya. Sorry, I was trying to unmute myself and it said I wasn't allowed to. Thank you so much for having me, everybody. It's so good to see so many of you on the call. Let me just quickly share my slides. Now, can you all see this in full screen?
Yes.
Fantastic. Great. All right, so as Ahil mentioned, I'm going to be giving you quite a quick whistle-stop tour today of some of the work that we're doing in Public Health England and in collaboration with a lot of our other stakeholders, working through migrant and inclusion health issues from a public health perspective, particularly during the pandemic. And I thought today I'd introduce myself a little bit because, as Ahil mentioned, I'm not actually that far into my public health career. I only graduated last year from UCL. And so I thought I'd give you a little bit of a rundown on who I am and where I've been. And then I sort of thought I'd introduce the topic of migrant health, not in too much detail, because I'm sure a lot of you who are interested in this topic already know quite a bit about it. But then also to touch on inclusion health, because we have been doing a lot more work, I guess, bridging the gap between migration health specifically and also other intersecting groups. And then I'll get down into what we're doing in public health at the moment broadly, before then going into the stuff that I'm sure you're all looking forward to hearing, which is what we're doing during the pandemic. And then hopefully at the end, we've got probably about 15 or 20 minutes to have a discussion and hear from you. So I'm a twice migrant myself. I was born in China and I was quite ill as a baby, and my family had very poor experiences of the healthcare system back then in the 1990s. And so that was one of the things that motivated them to migrate to Australia. And I joined them in Australia at the age of 5, did all of my schooling there, and then studied speech and language therapy and worked as a paediatric speech and language therapist at one of the tertiary paediatric hospitals in Australia. And it was there that I started to realize that, well, healthcare access isn't all that great either in countries where we would expect the healthcare system to be quite responsive. And so I started doing some research and trying to find pockets of funding to essentially study how healthcare access was potentially impeded by some of these factors that we know are at play for our migrants and our ethnically and linguistically diverse patients, particularly also looking at interpreting and translating for those who experience language barriers. And then I realized that I didn't know a whole lot about anything, so I decided to come to the UK, and I came over as an international student this time. and joined the Students for Global Health at UCL as well. And I did some work placements and volunteering alongside that, which essentially landed me these jobs that I'm in at the moment. So working as a research associate at UCL, and also now working as the National Migrant Health Lead at Public Health England. And also I got into some charity work too, being a trustee as well for a charity called Refugee. So, migration health. What do we mean by migrant? I think this is maybe a time where we could take some answers in the chat box, or feel free to yell it out. What do we mean by a migrant? How would you define it? Is there anything coming up in the chat box, Ahil?
Not yet. I've also enabled the function that if anyone wants to unmute their microphones, you're more than welcome to. So now's your chance to unmute.
Oh, here we go. I think some things are coming up in chat. Now let's see if I can see it. Oh, I don't think I can see the chat. Could you read that out, Ahil?
Sure. So we've got from Elena, someone who lives in a different country to where they were born. Rebecca said someone moving between different contexts. Matilda said someone who's moved from a different country. I think movement from one country to another seems to be a recurring theme.
Yes, absolutely. And I think that's probably the easiest part to define when it comes to migration. But this definition that we usually use from the International Organization for Migration touches on some factors that make it a little bit more complex than just moving from one country to another. And it talks about how, you know, as long as you cross an international border, or within a state away from your habitual place of residence, you can be classified as a migrant, regardless of your legal status, regardless whether that movement is voluntary or involuntary, and what the actual causes are for that movement, and also what the length of stay is. And we know that in the UK, you know, we have all different classifications. We might not call, for example, temporary overseas visitors migrants, but actually it falls under this broader umbrella definition that's used by the IOM. And we do also have to think about migration not so much as a static concept, because we know that there's really complex migration patterns. And also there are different definitions in different countries too that we should be aware of when we're reading the literature. And also that migrants, they're quite a heterogeneous population. And also migration can be circular and quite dynamic. So people can move in between countries, you know, their whole lives without ever really being, you know, static in the one place and having finished their migration journey. And the migrant population in the UK is quite diverse. And looking at 2019, approximately 14% of the UK population was born in a country other than the UK. And we've got all of these different categories that we like to group people into as well. You know, are you an international student, or are you a worker? Have you come here to join your partner? Are you a refugee? Are you an asylum seeker? Are you even an unaccompanied asylum seeking child? Or are you an undocumented or irregular migrant, which the media loves to call illegal migrants? So we like to think that people fit in these neat little boxes, but actually a lot of the time they don't. And that's good to be aware of. Now, another bit of fun pop quiz for you. Do you think that long-term migration to the UK increased or decreased in the lead up to Brexit? Can we get some answers in the chat for this too, Ahil? And if you don't mind reading them out.
So far, an overwhelming majority have gone for decrease. One increase from Hetty, but the rest of them.
Hetty, I love how brave you are. And you're right, actually, in that it did increase overall. And I'll show you this. So when I say Brexit, it is a little bit of a trick question because, you know, Brexit has been going on for such a long time. But what I mean is prior to the initial start date of when the UK left the EU. And you can see that actually net migration towards the end of this graph, coming up to March 2020, was increasing. And emigration, which is movement out of the UK, had stabilised really during this whole time. And we also see there's been an increase in non-EU migrants, which is what we would expect to, but also stabilisation of EU migrants. I think there was a lot of, speculation that potentially migration from the EU would decrease dramatically, but actually you can see in that yellow line that it's stabilised in the last few years. And what about the most common reason for migrating to the UK? Any takers? What do you think? Is it to accompany another migrant, to seek asylum, to study, or to work?
Mostly work so far, a few studies, and then, studying and work.
Studying and work? Yeah, you're right. It is to work. And that's what we know from long-term migration statistics. But of course, we know that our data capture of other types of migration isn't as well documented as long-term migration. And then when it comes to the health of migrants, I'm sure you've all seen these kinds of headlines in the media. And migrants are often framed as this sort of vector of disease that brings in all kinds of diseases to the UK. And we do know that some migrants, they may actually have quite a significant burden of infectious diseases, and that's largely dependent on, the prevalence of that disease in their country of origin or their exposure prior to and after their arrival into the UK. But actually, we know also from the literature that they pose very minimal risk of spreading that infectious disease into the general population to make it a real public health problem. And what about mental health conditions? Do we think that mental health conditions is higher in migrants than the general population? Any takers there? True or false that it's higher than the general population?
100%, not 100% now, around 95% for true.
Was it Hetty again that said false?
No, it's someone else this time.
Okay. Well, it's actually quite a grey area, this one. And for mental health, we've actually got quite a mixed bag of evidence here. But we do know that there are consistent findings that victims of trafficking, especially for sexual exploitation, victims of political and direct violence, and also migrant detainees have higher prevalence of conditions like PTSD, depression, and also psychotic disorder. And I won't ask you this question, I'll just talk to you about it. So why do migrants have an undue burden of some diseases? And that's based on a lot of things. And we've touched on some of these already in terms of their country of origin, their disease epidemiology in those countries, but also the socioeconomic and environmental conditions in which they live. And also keeping in mind that healthcare is quite different in different countries. But also the journey as well, their mode of travel, the duration that it takes for someone to actually make that move, and the circumstances around that, as well as that breaking of social ties, can also impact on migrants' health. And when they come to their destination country, which for us is the UK, well, there's their legal status to worry about and the policies around around different migrants with different legal status. We have differences in working conditions and living conditions, and also language and cultural differences. And we can't underestimate the effect that social exclusion and discrimination and racism has on migrants as well. And inclusion health is a term that I've decided to, I guess, include in this presentation today because of the fact that it is gaining some momentum, I think, in the political sphere and also in popular discourse. And inclusion health really refers to any population that is socially excluded, and quite severely too. And so this can include people, and some of these people some of these populations you've already touched on in previous webinars in this course, is people who experience homelessness, people who experience drug and alcohol dependence, and vulnerable migrants, which largely refers to those who have come over to the UK involuntarily, like our asylum seekers and refugees. And also gypsy, Roma and traveller communities, sex workers, people who are in contact with the justice system, and victims of modern slavery. And I've decided to include this because there are, we can't just lump people into a single group, that often there are quite large intersectionalities between some of these groups. And for example, homelessness, we know that the asylum seekers at the moment who have been housed in temporary accommodation, they also fall under this definition really of homelessness because they don't have a fixed abode. So we have to keep this in mind too when we're lobbying for one particular group, because there are lots of overlaps as well between these populations. And why do these inclusion health groups have extremely poor health outcomes? Well, a lot of that comes from that social exclusion, and there are multiple risk factors for their poor health, including that poverty, violence, and complex trauma. We've talked about stigma and discrimination, barriers to accessing healthcare. And this one's interesting too, that, socially excluded groups are not accounted for very well in electronic health records, which means that we have very poor intelligence on their health, and quite poor quality data that we can work with to understand their health. And also that insecure housing and living in communal accommodation and overcrowding has been a particular issue, particularly during the pandemic, which we'll touch on later. So this really gives rise to that cliff edge. So rather than being, a nice slippery slope towards poorer outcomes, it's quite a shocking cliff edge when it comes to poorer health outcomes for these populations. So now that we've gone through a bit of introduction on these topics, I thought I'd give you a bit of an insight into what the Migrant Health team at Public Health England does. And this is, I guess, taking into account what we're doing still during the pandemic, but also what business as usual looked like for us too prior to the pandemic. So Public Health England has this strategic plan that has 10 different objectives. And you can see down the bottom that they've also decided to incorporate the reduction of health inequalities into each of these top 10 priorities. And that's where migrant health also comes in. And that essentially sets the precedence for a lot of the things that we do. So our team largely, we provide a public health approach to improving migrant health. And what that looks like in practice is that we give advice and guidance to government and non-government agencies. We develop strategic partnerships, and also we work in collaboration internally and externally to our organisation. We do a lot of generating and reviewing evidence too to support policy and guidance. So having a good research skill set definitely came in handy when I first came into this role. And we are now starting to contribute to broader inclusion health work. And in the last year or so, a lot of the teams within Public Health England that previously worked on, for example, rough sleeping and isolation, or worked on migrant health, or working on drug and alcohol dependence, we've come together to form an inclusion health sort of a larger team to be able to account for these overlaps. And that's been particularly helpful during the pandemic, which I'll touch on soon. And these are some of our stakeholders. So you can see on the left and also in the middle that we work with a lot of government bodies, but also we work quite closely with the NHS, and in particular NHS England and Improvement, their health inequalities team. And to the right, we also work closely with the International Organization of Migration and Doctors of the World, and also other, local and voluntary sector agencies. For example, Family, Friends and Travellers, which is an organization that works closely with Gypsy, Roma and Traveller communities. And so one of the things that I do on a day-to-day basis, and this has become quite important during the pandemic as well, is to maintain the Migrant Health Guide. So if you click on this link and go through to the Migrant Health Guide on the gov.uk page, it has all of the, essentially all of the compiled guidance there on a range of health topics to do with migrants. And it's a resource that's aimed at healthcare professionals to support them to take, I guess, both a public health sort of approach, but also looking at health inequalities and trying to improve the health of migrants. And it has lots of different pages. For example, we developed a COVID-19 page that has translated resources signposted, and also charging exemption translated messages too for, free vaccine, free treatment, and also free assessment as well. And we also have a page that's quite popular, the NHS entitlements page, and that's updated quite regularly to reflect the most recent policy advice on things like charging and access to free services. A new language interpreting and translation page has been developed. And also we've got other pages, for example, dental health, that have recently gone major revamps. And we will soon have animated videos as well uploaded to really explain this complex entitlements topic as well, and also the topic of vaccinations too. So watch this space, it uploaded in the next month or two. I'm currently also working on a project to look at refugee pre-entry vaccinations. And essentially there is a protocol that Public Health England helped to create to essentially ensure that refugees get their health assessments and also a set of minimum requirements for vaccinations before they come over to the UK. But we identified that actually we need to improve vaccination prior to and following their entry into the UK. And the best way to keep on top of that was really to provide some real-time data and intelligence for this. So we're currently working with the International Organization for Migration to create dashboards and regular reporting for this particular topic, because we know that once refugees come over to the UK, that they need to, essentially, a lot of them need to catch up on the schedule of vaccinations as well to protect them, but also to protect the community from infectious diseases too. So that's something we're working on at the moment. And some of you may have seen this resource. All Our Health is a framework that's been promoted by Public Health England in the last little while, and there's been multiple collections developed under the All Our Health framework. And one of them recently that we've published is the Inclusion Health resource. And again, this is intended to provide advice to healthcare professionals to take action using a public health approach. So you'll find a lot of good resources and e-learning, as well as some meaningful action that we've outlined for frontline healthcare workers, for managers, for strategic leaders as well, on this particular page. And to make it more digestible for you, here's an e-learning too that you can access. You can see Inclusion Health down the bottom, but also other related topics like homelessness and also immunisation as well, have e-learning pages too. Something else that I've been working on too is social prescribing for migrants, and this came up earlier last year as something that, you know, given that the NHS long-term plan has incorporated social prescribing as a major part of what the NHS is going to look like in future, that we really wanted to know, is this a really good model for providing care to migrants? So at the moment, we're in the process of writing up a rapid review and a call for evidence to have a look at how something like social prescribing works for migrants. Does it work in the UK? And there's some, if you wanted to understand a little bit more about the project, but we anticipate that recommendations will also go up on the Migrant Health Guide on gov.uk. And without going into it too much before getting stuck into the COVID part of this presentation, we also work quite closely with the Department of Health on the topics of charging regulations and cost recovery. We're also currently trying to sort out some data sharing, clear messaging, which again I'll get to later in the COVID section of this presentation. We also help to maintain the recommendations for pre-entry health assessments for UK-bound refugees. And right now we're also trying to improve the data flows actually between these pre-entry health assessments and GPs, because GPs often don't receive the amount of information to be able to provide and take over the care of these refugees when they come to the UK. We also provide advice to the Home Office on refugee and asylum seeker resettlement from a public health point of view. And there's a lot of different strategic groups that we're involved in at the moment as well. For example, there is a 4 Nations Migrant Health Strategic Working Group, an Inclusion Health Working Group. Doctors of the World also have an expert consortium on refugee and migrant health that we provide input into. And a COVID-19 inequalities group was also convened between NHS England and Improvement, Public Health England, and also Department of Health and Social Care. All right, so after that whistle-stop tour, COVID-19. This is all probably the more interesting part of this presentation. And I'll take you through some of the things that we've been able to influence during this time. background to all of this and what's really guiding us through this is the evidence that we know that there has been an increase in total deaths during the pandemic period, more so for those who were born outside of the UK than those who were born inside the UK. And you can see that quite clearly in this graph here, especially for Central and Western Africa. You can see where the relative increase in deaths compared to pre-pandemic for people who were born in Central and Western Africa was about 4.5 times higher than prior to the pandemic. And you would have all also been aware of the Joint Committee on Vaccination and Immunisation, their prioritisation schedule, which is still currently being implemented as part of this vaccine rollout. And one of the things that some members of our team provided input into is this guidance paper on how it is that we weigh up the scientific evidence and the ethics and also the deliverability and the implementation factors of vaccinating specific vulnerable groups. And I encourage you to have a look at this paper because it was quite a good learning for me as well to see how it is that we balance all of these different factors and decide who it is to prioritise in the end. What we did after this, initial JCVI prioritisation schedules with the top 10 priority groups was published, was we had a look at these priority groups and we thought, well, actually, a lot of the groups in these inclusion health, in these inclusion health groups, they have a lot of vulnerabilities as well that I think, we should be prioritising and that we should be considering too when we roll out the vaccine, and they weren't accounted for in the initial JCVI priority groups. So Public Health England, all of our inclusion health groups, we collaborated with some of our academic partners at UCL, and we created a paper that I've attached and sent to Ahil, so that could also be disseminated as part of this if you're interested in reading it. We developed essentially an evidence-based briefing, like a policy brief, to present at one of the COVID-19 subcommittee meetings. And that was really interesting to go to. There were about 60 people on this call, all very esteemed, panel members in this committee. And we presented the evidence for why it was that inclusion health groups needed to be prioritised and prioritised much sooner than the previous vaccination schedule. And in this paper, we discussed that outreach was an evidence-based option for these groups who otherwise would have difficulties accessing the vaccines at traditional vaccine sites. But also we need to consider this recommendation in context because it could also be quite stigmatizing and have counterproductive effects if we're targeting, specific groups. And that meant that we needed to work with very trusted organizations to make sure that outreach was successful. And the outcomes of this were all actually quite positive in that you may have seen the release of this letter from the Health and Social Care Secretary. It was only earlier this month, where he accepted the recommendation to include the homeless population as part of Priority Group 6, and they weren't previously. And the great thing about that was that NHS England and Improvement immediately followed up with disseminating a mobilisation guide, which I've also included the link to there. And you can see as part of this mobilisation guide that it mentions specifically asylum seekers, who I mentioned before, don't have fixed abodes, so technically also fall under this, this definition of homeless. So now they can also be reached as part of Priority Group 6, which is much sooner than otherwise. And also in the broader inequality space, NHS England also produced some guidance for clinical commissioning groups to increase vaccine efforts for some of the more vulnerable groups in our populations too. So that was a really positive outcome. Other vaccine considerations that we're still trying to work on right now. And one of the biggest things that I alluded to before was this issue of data sharing. And you may have seen in the news these headlines like no deportation risk for illegal migrants getting the vaccination. So essentially saying, come get the vaccine, we won't deport you if you come. We won't share your, undocumented status with a Home Office and kick you out of the country. But unfortunately, it's not as simple as that. And for anybody who knows anything on the data sharing agreements between the Home Office and NHS Digital would know that there's been a long history of trying to figure out whether or not the Home Office and NHS Digital were going to share data, personal data, on migrants with irregular migrant status. And we're at the moment, as much as nothing has necessarily changed during the pandemic, we're trying to get clearer guidance from the Home Office, from the Department of Health, because we're hearing that from the front lines that this fear of being reported and having their data collected is really deterring asylum seekers, irregular migrants from actually attending for their vaccinations, because they're scared of this risk of sharing their data and the consequences of that. And also data collection too has been quite difficult, because we're trying to understand how inequalities are playing out during the COVID vaccine, but we actually don't collect good enough data as part of healthcare records to really understand who is uptaking the vaccine from a migrant perspective. And what we're trying to do at the moment is we're trying to get country of birth data alongside homelessness data collected at the point of vaccination. And that's currently going through a long process of approvals and discussion about whether or not we can collect this data just now. But we're crossing our fingers that we'll be able to get this data soon. So we'll be able to provide some kind of intelligence about the level of uptake in migrant populations. And then also looking at vaccine confidence. There's been a lot of media attention on this sort of vaccine hesitancy and myth busting and essentially blaming certain populations for not attending for their vaccine. But there isn't actually a whole lot of evidence out there yet on the uptake of vaccines in specific populations. And often vaccine hesitancy is conflated with vaccine uptake without considering the fact that actually vaccine access is a big issue too, that it might not be that everybody is super hesitant in specific groups to access the vaccine. It might also be because of the fact that they have difficulties accessing it. So we're trying to, I guess, provide advice as well and support some of these efforts to improve vaccine confidence within specific communities, but also keeping in mind how can we do that without sort of resorting to, blaming certain populations for not looking after the health of the general population by not attending for their vaccines. And you have probably also seen that translated communications are coming out at an unprecedented rate, and Public Health England really has focused a lot on developing, very timely in multiple different languages, and Doctors of the World as well are helping at the moment develop vaccine communications in community languages. And I also thought I'd include this link here for anybody who's interested. Groundswell is another organisation that has developed some really good, very simple vaccine implementation guidance for inclusion health groups, which I encourage you to look at. But essentially, vaccine delivery on the ground is still very much trying to figure out what the best way is of reaching some of these more marginalised populations. And then moving on from vaccines, something that also continues during the pandemic is refugee resettlement, which I think has been forgotten about a little bit. And that's probably because IOM and UNHCR, they announced a temporary suspension of refugee travel in March last year due to travel disruptions caused by the pandemic. But resettlement arrivals to the UK, it restarted again in December 2020. And so what we had to do was produce a new set of public health recommendations for the Home Office about how we can safely resume refugee resettlement in light of these current restrictions in place during COVID-19. And that is essentially intended to accompany the existing guidance already on pre-entry health assessments as well for the UK. Something else that's gotten quite big media headlines is this issue of contingency accommodation for asylum seekers, and how these, initial accommodation centres are managing COVID-19 and COVID-19 outbreaks. And this has really received a lot of, media scrutiny. There's been heavy political, legal and public scrutiny as well around this topic. And you would have seen the news articles as well on the different barracks and hotel accommodation as well. But essentially the Independent Chief Inspector for Borders and Immigration initiated a call for evidence, which we submitted to as a team. And they were essentially trying to have a look at, what the current state of play was in terms of managing COVID-19 in these initial accommodation centres for asylum seekers. And I encourage you to have a look at this link that I've included here, which was the initial inspection findings of the Independent Chief Inspector. So they visited, I think it was 2 of the barracks, I think twice in 2 different weeks, and they provided a key summary of what the conditions were like in the barracks. And there are actually photos as well that they took and attached. And I encourage you to have a look at some of their findings. And some of the findings that they did see, that they did observe, was in keeping with what our partners on the ground in local teams had reported to us as well. At Public Health England, the Migrant Health Team, we convened a lessons identified debrief in December 2020, and that was essentially pulling together all of our regional migrant health teams and local teams to provide us with a bit of insight into what was happening on the ground in terms of these asylum seeker accommodation centres and how COVID-19 was being managed. And off the back of that, we produced, and this is publicly accessible as well, we produced guidance for the providers of accommodation for asylum seekers too, essentially touching on topics like, how to maintain social distancing and what kind of requirements should be put in place for that, and also what kind of considerations should be made in terms of transfers between accommodation settings during the pandemic. So that's all there for you to have a look at too, if you're interested. And so some concluding thoughts and reflections. Essentially, COVID-19 has really further highlighted these disproportionate risks for migrant populations, and particularly vulnerable migrant populations like asylum seekers. And we've also discovered that evidence, well, we always knew this, but also in the pandemic, that evidence really has been quite crucial to strategically influencing policy and public health action around this, for example, in the case of the vaccine prioritisation. And we really can't underestimate the importance of clear guidance. And during the pandemic, particularly in this year, we've noticed that the number of page views on the Migrant Health Guide has been skyrocketing. It was sitting at around 9,000 page views per month for the whole guide in 2020. And as of this month, we've hit about 19,000 views just for this month alone. So it seems like there has been a lot of interest in seeking clear guidance and advice. And also, collaboration and joined up action between sectors and also between inclusion health groups has really gotten us to where we are right now. For example, we know that homelessness is quite high on the political agenda at the moment. And I think if we went ahead and lobbied for asylum seekers to be prioritised in the vaccine efforts, we potentially would not have gotten as far as we did, as what we did by advocating for inclusion health groups overall. And of course, as always, there's challenges navigating these politically sensitive issues, and also the fact that there's been, a lot of influences on public perception as a result of the media around this. And I think moving into the future, what we have been doing largely is, reacting in our public health response to some of the issues during the pandemic. And it would be fantastic, and what we're trying to do is take a more proactive approach to looking at how we can embed some of these good learnings into the future so that we are prepared, in this next stage of navigating the pandemic and also beyond that as well. So thank you. I'll stop sharing now and look forward to discussing this with you if anybody has any questions or reflections or questions.
Very much, Claire. Really appreciate that. That was amazing. A lot. Yeah, now, as you said, time for questions. So if anyone has any questions, please, you can either unmute yourself or you can put in the chat section, also at the end of the event, Ahil has some announcements to make as well. So yeah, questions. Wants to start off?
Or even any kind of reflections or anything that you found interesting, or an interesting approach that you wouldn't have thought of, or
I can start
anything
off.
you think. Yeah,
just
go
go
for it.
ahead. I think one thing that really piqued my interest was the refugee pre-entry vaccination program. I just thought it was quite intriguing, and I wondered what mechanisms are being put in place to do that, and like, are they, how widely is that going to be rolled out, if you know what I mean?
Yeah, absolutely. So the refugee and pre-entry health assessments have been around for quite some time. And essentially it's efforts that are coordinated by the UN and International Organization of Migration with the member states. So prior to these refugees coming over, so they receive, their refugee status prior to, coming over to the UK, and they have to have this big health assessment. And it's a huge document to read, and it's available online. And I think I put the link in the slides as well if you want to have a look at it, but it's a massive document on essentially screening them for every possible communicable and non-communicable thing. Well, not so much screening, but a lot of it is also case history taking. And as part of that, they look at the vaccination schedules of refugees. And what the intention is that you'll see as part of that guidance that the UK has produced, that there are sort of this minimum set of vaccines that should be had prior to coming here. And that includes things like measles, polio, if you're coming from an endemic country, and also hepatitis B, if you're in close contact with someone who is Hep B positive. But what we're seeing is that despite these, minimum set of recommendations, that actually the member states who are sending refugees over aren't necessarily, and potentially don't even have the capacity to be able to administer these vaccines prior to them coming over. So what we're trying to do is have a look at, well, what vaccines as part of, the UK schedule are missing in these refugees' vaccination histories. So what can we be encouraging member states to be doing prior to sending refugees over? But what can we also do in the UK, knowing that their vaccination statuses are incomplete? What information should we be providing to primary care in order for us to be picking that up quicker and playing catch up essentially with their vaccination schedules a lot quicker once they do arrive?
Very much. That makes it a lot more clear in my head. I appreciate that. There's a question in the chat section from Nazar. She says, just wondering, can you suggest any documents to advise on pregnant refugees/migrants and right to health access?
Yes, absolutely. So probably the best place to start is the NHS entitlements page, which is part of the Migrant Health Guide. And all you have to Google is NHS entitlements migrant health, and that'll be the first thing that pops up on Google. And there is a section from memory about pregnant migrants and their access to care. Particularly, I assume you're also talking about antenatal care as well. And I'm trying to remember the name of the organisation that provides quite a lot of good guidance on this. I'll get back to you. I'll do a quick Google and get back to you. But there is definitely an organisation, and I can't remember if they're called Migrant. It's specifically specific to migrant women, and they provide a lot of informational resources about access to care. So I'll get back to you on that one.
She says, lovely, thank you. And there's another question from Eleanor who says, thanks for such an amazing, engaging talk. Which is great. Could you give some examples of how outreach to vulnerable groups, e.g. to encourage them to take up the COVID vaccine, can be stigmatizing, and how we can avoid this? Cool.
Yeah, absolutely. We've been discussing this quite a lot within these different inclusion health groups. And this actually came up as part of a discussion with family, friends and travellers. So they represent the Gypsy Roma traveller communities. And they were essentially saying that sometimes by pointing out the fact that specific groups have low uptake, and then saying we're now going to do targeted messaging, and we're now going to specifically come to you, with a needle and jab you, is quite stigmatizing depending on who it comes from. So for example, if we now released a government message that said the government now wants to vaccinate all asylum seekers, and we're going to target you now for the next outreach. I don't know about you, but if I were an asylum seeker, I would feel like, is there some kind of ulterior motive to this? Why is it that we need to be vaccinated? And we know that historically, a lot of these marginalized groups have been the subject of essentially trials and medical trials and tests. And for something like, you know, the newness of the COVID vaccine, they could potentially think there might be some ulterior motives to why we're being targeted quite early on. So that's why I think sometimes we have to be careful when we're talking about targeting specific groups, because you know, it could be perceived in the wrong way and actually deter people from accessing the vaccine in the first place. So that's why it's so important, if we are doing outreach, to be doing that with trusted partners who have already got really great relationships with these communities, rather than now, you know, giving a government message saying all asylum seekers come forward, you won't be deported, and here's the jab, if that makes sense.
Well, it does to me, so thank you very much. There is a question from Asha, which I think you've addressed. You want to take a look at what strategies do you think could be used to challenge misinformation? I think a more interactive, what you're suggesting is a strategy with organizations who are very embedded and grassroots, and I guess have a direct contact with them, if that's the one. I hope I'm not listening to what you said.
Yes,
I think you've answered that question.
Is this
Asha.
Asha, yes. Oh, is this a strategy? So strategies you think could be used to challenge misinformation or fake news? This is also a great question, and I don't profess to be an expert in this area. We do have teams specifically within Public Health England who are currently working on this particular issue. One of the things I have heard from them advice is that, you know, essentially hitting these myths on the nose potentially perpetuates them. So if you retweet somebody's tweet saying that, you know, there are no pork products in the vaccine, then it's likely that someone somewhere will take that, will chop it up into pieces and then retweet it as there are pork products in the vaccine. And you never know, actually pointing out some of these myths could actually perpetuate them, because it's keeping it circulating in popular discourse as well. So I know that some of my colleagues in Public Health England are trying to develop information and guidance that doesn't necessarily perpetuate the myths, or doesn't necessarily hit these myths, you know, straight on the nose, but what they're trying to do is provide the real facts around it. So what is true, they're trying to circulate, you know, more in the community. And I'm just having a look at what else was in that particular question. Fake news and feeding into stigma towards migrants that can impact poorly on their health. I'm not sure if that's part of the same question. My interpretation of that question, Asha, and feel free to clarify this. Are you talking about essentially fake news as in blaming certain migrant populations for not coming forward? Perhaps if you can clarify that question, we can come back to it.
Sorry, yeah. I meant sort of towards vaccination, and then being a bit more sort of general and a bit more broad in terms of just maybe accessing like healthcare in general, not necessarily specific to vaccination.
Sure. So how can we challenge misinformation around what their entitlements are to accessing healthcare? Is that?
Yeah.
Yeah, and I think a lot of that goes back to referring people to the right sources of information. So the Migrant Health Guide is essentially the catch-all for all the information, and a lot of the guidance on there has been cleared by, for example, Department of Health as well. So we make sure that whatever information is on there can be traced back, you know, to the policy guidance that's currently in place. So I think, you know, if you were to start off with anything, I would say provide people with information straight from guidance that you trust, like, for example, on gov.uk. And also, I would say too that I guess providing that information in a way that can be accessible to the communities as well. For example, one of the things that we found in a stakeholder consultation was that the NHS entitlements page on the Migrant Health Guide was super dense. Like, there is a lot of technical information on there about who gets charged for what. And that's why we've decided to create these really short and cute animated videos, because we know that people really are only going to, you know, be on there for a few minutes at a time, and they just want the key information on there too. And so part of challenging misinformation, is to simplify and to provide, you know, the key pieces of information that people can find digestible. And then if they want to look for more, then it's all there as well.
Asha says thank you. We have one more question from Rebecca. If she wants to mute, she can. Nope. Okay, cool. I'll just read it out. From a public health perspective, how important do you find it to be to distinguish between different groups when it comes to improving access to healthcare?
That's a really great question. And I guess I'm thinking, in answer to this question, it's a tricky one, because as much as it is really important to understand people's migrant health journeys and how vastly different they can be, sometimes by chopping up this broader category of migrants into smaller groups, it doesn't necessarily make things easier when it comes to, you know, advocacy efforts or influencing policy. I think there are definitely specific issues that are more pertinent to one, I guess, category of migrant than other. But I guess when it comes to improving access to healthcare, we know also that there are so many barriers to accessing healthcare that are quite similar across all these different categories, if you will. For example, you know, a simple one is language barriers. We know that is going to be a huge issue in all of these different subcategories of migrants. We also know that in terms of, you know, for example, housing issues, or in terms of not having fixed abode or living in overcrowded, you know, residences, is quite common as well amongst economic migrants who are in poorer working conditions and living conditions too. So it's not just specific to asylum seekers or refugees that we're talking about overcrowding or the conditions in which they live and they work. Of course, there are also specific barriers too. For example, that fear of data sharing doesn't apply to all migrants that are out there. So I guess it depends on what access barrier you're trying to address as to which, you know, whether it's the broader migrant population that you're trying to capture under this particular issue that you're trying to advocate for or lobby for, or is it that there are quite universal access barriers that we really should be addressing for all migrants out there. So I guess it depends on what particular barrier you're looking at when it comes to access to healthcare.
That's a response. Thank you. By the way, Ahil, you feel free to unmute after Matilda's question. So we have a question from Matilda, which says, how do you communicate information to those who do not have access to technology, as it feels like a lot of the public health information is on TV or online?
That's such a good point, Matilda. And, you know, digital exclusion has come up as such a big issue, not just for migrant populations, but for the general population as well, particularly during the pandemic, now that everything's, you know, virtual. And I think unfortunately, a lot of advice and guidance is online, as you've mentioned. I think there are pockets of work being done. For example, I'm not sure if any of you have seen the GP Access campaign, the GP Access cards that I hope are doing the rounds at the moment. So NHS England and Improvement created these little yellow cards that you can access, you know, physical copies of, and that should be, I think they have been distributed, you know, on the ground as well in physical form, to help migrants, to help any sort of inclusion health or social excluded group to be able to bring that card to their GP and say, you know, I do not need to prove my identity, I do not need to prove my immigration status, and I do not need to prove my proof of address in order to register for your practice and to access your care. And these kinds of resources so they're both doing digital campaigns, but they're also trying to do physical, I guess, campaigns and get these resources and messaging, and there's posters and things like that for GP practices to be putting up. So I think there is definitely that the paper copy of a lot of these you know, advice and guidance materials that are being disseminated. But I do agree with you that the majority is online. And at the moment, unfortunately, I have to say, at least within our team, a lot of stuff is online, and it's a lot of the time up to some of the I guess, our stakeholders who are working much more closely with local organisations that are often thinking about these kinds of issues, because we're very much an arm's length body. We provide the sort of content behind the advice, and then it gets mobilised through the stakeholders that we work with.
Ahil, your question?
Sure. Thank you very much for the talk. It was really interesting. My question's about a particular video that I saw circulating on social media sometime last year. It was, I think, some members of the public who managed to get inside a hotel and videoed sort of asylum seekers living in what looked like quite comfortable conditions in a fairly sort of 4 or 5-star hotel. And I'm sure there was you know, a lot of context behind it and stuff, but I just wanted to ask what your thoughts were on, you know, videos like that and sort of people trying to interrogate, you know, these migrants circulating on social media and sort of worsening this narrative that, you know, migrants come from other countries to use up UK resources and stuff, which I definitely don't agree with that narrative at all, but it was circulating on social media. I'm not sure if you've seen that video, but I just wanted to ask what your thoughts were on that.
Absolutely, Ahil. And yes, you're right. I think these days anything and everything can circulate and go viral online. And I think it is quite a shame that, and it always has been the case, that migration is such a heavily politicized topic. And so we will always get, you know, different ends of the spectrum being broadcasted, you know, all over the internet as well, and right in front of our faces. I guess when it comes to, again, it probably comes back to, you know, the dealing with misinformation. I think for people, and I would probably assume that everybody on the call would also agree with you, that, you know, even if that is one particular migrant's experience living in a luxury hotel, that is not the experience of everybody out there, whether or not that video is genuine or not. And I think it's just keeping in mind that when we continue to circulate information that we believe is not true, or that we don't agree with, that is also feeding into the fact that it's going to continue to do the rounds. So I think people have different opinions of whether to address something, you know, right then and there and call it out for what it is. And some people say it's probably good to back off and let it die down. And I'm not a behavioral scientist and I'm not sure what the best way to deal with it is. But I think a lot of the things in the media, you know, take with a grain of salt and see if you can find, you know, the real information behind it, before, I guess, continuing to forward on some of these videos and some of these posts. I'm trying to remember, you said something else towards the end of your question that I was wanting to address, and now it's just left.
Maybe just to clarify, I didn't forward that video onto anyone. It was just that
I'm sure you didn't.
it was quite emotive, and like it did trigger quite a few emotions in me. The attitudes towards these asylum seekers, because like you said, I'm sure for many migrants their experiences are quite different. Maybe the latter part of my question was more of a comment on how a lot of public and society's attitudes towards migrants is, you know, they're coming from another country, using our resources, taking up
overutilizing
spaces in schools, hospitals, etc. And what your thoughts to that were.
Well, my thoughts to that is I did my master's dissertation on this topic, and we're currently in the process of writing up some papers for publication at UCL about utilisation of healthcare resources. And I think that this topic, it has gotten a lot of attention and a lot of bad rhetoric around it that is not justified in the evidence, because we are actually one of the first to actually publish any kind of you know, research paper in the UK on healthcare resource utilisation and, you know, the frequency of healthcare use for migrants compared to non-migrants. It hasn't really been done before, other than using survey data. We've never actually, for example, gotten healthcare records and seeing, is it actually the case that consultation rates are higher? So my answer to that is good research, and hopefully some of that will be coming out soon from UCL. But you know, good research is a way to to, I guess, shine a light on what actually is happening as opposed to what the media is choosing to present. So I always encourage all of you, if there are topics that you're interested in, to honestly just do a quick evidence search and see what's out there. And a lot of the time you'll find that a lot of this isn't justified in terms of, the burden on the NHS of the migrants coming over. And today I was actually in a Doctors of the World's a meeting about this, in which they had done a policy analysis exercise on, for example, cost recovery. Like, we should be charging migrants for the care that they use. And what was actually found was that, a lot of the migrants that we're charging don't actually have the money to even pay for the services in the first place. A lot of them are destitute. But also the money that's recovered through these schemes isn't really a whole lot either. And I think that also speaks to the fact that some of these claims of overutilization is quite unjustified too.
Very interesting. I find that particularly intriguing because I'm a politics student, so the politics side seems just quite exciting.
Absolutely.
Yeah, as well.
It's something that I think the IPPR are going to be publishing this report that they're doing, this policy analysis that they're doing on charging. So I encourage you to keep an eye out if that's something that you're interested in.
Well, yeah. We have a final question, I think. Someone says, thank you for the presentation. And they ask, can I contact you by email? I am an international student from China and I'm doing a systematic review on access to healthcare for Chinese migrants in destination countries. It would be good to keep in touch with you.
Absolutely. I think my contact details, are they on the slides that were shared?
We will be distributing the slides that Claire presented with this evening, and her emails at the end as well. So if you fill out the feedback form, which I've just pasted in the chat, we can get your email address and get those slides across to you.
Thank you, Ahil.
Thank you very much, Claire. I've really enjoyed this. And it seems like everyone else is as well. So I'll hand over to Ahil to close off the event.
Thank you for having me.
I made the classic error and left myself on mute. But thank you very much, everyone, for joining us this evening. Hopefully you can see a QR code. Thumbs up, Sam. Can you see a QR code? Okay,
yeah,
cool.
we can.
So hopefully you can see a QR code which will take you to the feedback form. It's quite short and we really would appreciate if you could fill it out. It will help inform us when it comes to planning future events. A few announcements from me about some really exciting free events and conferences coming up. The first one is actually by STAR, and it's called Life's Labours Lost, Asylum Seekers and the Right to Work. It's going to be held on March the 30th, and it's a free conference as well. And Rebecca will post a link to the conference in the chat. There's going to be a number of workshops and talks throughout the sessions centered around their spotlight campaign, Lift the Ban. And it does look like it's going to be super exciting, so make sure you sign up for that. The second announcement is our own conference from Students for Global Health. We've teamed up with UAEM for our annual conference on price of life. And it's going to be centered around access to medicines with a particular focus on how prices and intellectual property law can impact this. And it's really important in the current climate, with all the issues with COVID-19 vaccine distribution and the impacts of vaccine nationalism. So do sign up to that as well. It's free and it'll be taking place over the Easter break on 10th to 11th April, a 2-day conference, again, with loads of workshops, talks. You definitely want to be there. And the final announcement regarding SFGH, keep an eye out via email and social media. We'll be running our elections for next year's committee. So if you want to get involved with planning events, making some real change in our university, definitely take a look and apply for one of the many roles that will be on offer. So stay tuned for that. And just before we conclude, I just want to say a massive thank you to Claire again for taking time out and speaking to us all on the very important topic of migrant health, especially during a pandemic. I learned so much myself. It was really, it was quite inspiring to see the work that Public Health England have done in making real change. And that was evident with the JCVI decision to include, marginalized and vulnerable groups in those top 10 priority groups. And as a control of infectious disease student myself right now, I've just come off a week full of lectures on vaccines and vaccine hesitancy, and it was nice to see it in action this evening. So once again, thank you very much, Claire. We will be distributing slides, resources, and the paper Claire mentioned in her talk at the end. Just remember to fill out the feedback form. And for those of you who have attended at least 4 out of 6 of this sessions in the short course, you will be receiving a certificate. So just remember to fill out the feedback form, and you should receive a certificate in due course. But thank you very much, everyone, for coming along. Hope you have a great rest of the week. And yeah, take care.
Thank you, everyone. See you later.